Good evening. I'm Amy Powell, Community Engagement Specialist for Pheo Para Alliance. I'm joined tonight by a panel from the American Association of Endocrine Surgeons. They'll all introduce themselves shortly. I just want to thank everyone for coming to the 5th Annual Pheo Para Awareness Week AAES webinar. As you know, this is our 5th year doing the Awareness Week, and I believe also the 5th year with the AAES panel. It's always a great and incredibly informative and educational evening, and I'm excited to be able to hand things over to Dr. Jennifer Rosen, who will introduce herself and the rest of the panel. Dr. Rosen, welcome.
Thank you very much. So I would really like to thank you for inviting us this evening, and it's been a really great couple of years coming. I'm Jennifer Rosen. I'm the Chief of Endocrine Surgery at MedStar Georgetown and Washington Hospital Center in Washington, D.C. I'm a very active member of the AAES, and I really appreciate talking with my patients about some of the complicated questions that they have. My job tonight is really just going to be to facilitate your questions and make sure that we get some answers. We don't have the answers for everything, but we're going to do our best to talk about the questions that you have. The intention is not to answer specific patient questions, but we'll turn it into some more general answers. And then we'll do a few minutes of wrap up at the end with our last thoughts. So with that, I'm going to turn it over to my co-moderator, Dr. Babanga.
Hello, I am Dr. Juliana Bobenga. I'm an endocrine surgeon practicing at Matthew Regional Medical Center in Palmer, Alaska. Very happy to see everyone here today. I would like to allow the other panelist members to also introduce themselves and tell us a little bit about where they work and what they do. I'll start with Dr. Bancos.
Hello, everyone. Really glad to be here. I'm actually an endocrinologist and not a surgeon, so it's even more special to be among my colleagues here. I'm an adult endocrinologist specializing in adrenal disorders at Mayo Clinic.
Thank you. Dr. Graham.
Hello, everyone. My name is Paul Graham. I'm an endocrine surgeon at MD Anderson Cancer Center. I'm also the program director for our endocrine surgery fellowship. Practice a variety of endocrine diseases, but like to specialize in adrenal disease specifically.
Dr. Patel.
I'm Neil Patel. I'm a otologist, neurotologist, and skull-based surgeon at University of Utah in Salt Lake City. I'm part of our multidisciplinary Pheo Para clinic and our PPA Center of Excellence. And my area of practice is primarily skull-based paragangliomas.
Great to have you. Thank you. And Dr. Shirali?
Hi, everyone. My name is Adi Shirali. I'm an endocrine surgeon. I'm at the University of Florida. My practice is devoted to the treatment of thyroid, parathyroid, and of course, adrenal tumors. I have a special interest in adrenal tumors and obviously pheochromocytoma and paraganglioma as well. And I'd like to thank everyone for having me today.
With that, I'd like to get started with a question. I'll address this one to you, Dr. Graham. I know that you see a lot of patients with pheochromocytomas and paragangliomas, and we all know of the typical presentation of very high blood pressure episodes, sweating, headaches, palpitations, but not all patients present with that picture. What are some of the less common ways that your patients have presented with pheochromocytoma and paragangliomas?
Yeah, thanks for the question. As you mentioned, a lot of patients present with classic symptoms: high blood pressure, palpitations, headaches, maybe hot flashes as well. But there are a slew of vague symptoms, and they can range in variety. That's kind of what's interesting and unique about this disease type, is that you kind of see rare presentations as well. So a lot of patients develop GI issues, either constipation or diarrhea. They may demonstrate skin and hair changes, either dryness or profuse blushing and sweating. They may show heat sensitivity, light sensitivity at times, some blurry eye changes. So those are kind of vague symptoms that patients may realize later on that they were suffering after they've had a diagnosis. Additionally, a lot of patients just show up asymptomatic, and that these are things that were found on imaging or after evaluation for benign, what they think is benign hypertension through a cardiologist or the primary care doctor.
So I have a follow-up question for that, which is, if those are the symptoms patients are presenting with, those are pretty non-specific symptoms. So I'm curious to hear how often patients you think how long it's taken for them to come for presentation, and how many of those symptoms can we expect patients to have resolution of after surgery?
Yeah, that's a good point. And as I alluded to, some patients kind of go a longer period of time with symptoms, these vague symptoms, before they're actually diagnosed. And I think many times it's the high blood pressure and the workup through multiple medical providers that eventually kind of leads to evaluation and of the catecholamines and the adrenaline hormones that these tumors make. We probably see resolution of a lot of those classic symptoms after surgery and after correction of the catecholamine levels. Sometimes the vague symptoms, if they overlap with other disease entities or comorbidities, it may be hard to say that those will completely go away.
And another follow-up question we have for Dr. Patel, head and neck paragangliomas, how often are they going to have a similar presentation? Or is it a sign of something more serious or more worrisome when patients with head and neck paraganglioma have those symptoms?
Yeah, so most head and neck paragangliomas don't secrete hormones. It's only about 2% that do. And so if somebody's diagnosed with a head and neck paraganglioma, either a glomus jugulare, vagale, or a carotid body tumor, or anything around the thyroid, and if they have symptoms of hypersecretion or biochemical testing that shows hypersecretion, the onus is actually on the provider seeing that patient to test or to look for another site of disease. So to look for an abdominal paraganglioma or pheochromocytoma, because it's so rare for a head and neck tumor to secrete.
Thank you. And just a follow-up question, Dr. Patel. If patients don't have typical symptoms, how are paragangliomas in the head and neck usually found?
Yeah, so that's site dependent. So just going from top to bottom, a glomus jugulare, the two most common symptoms would be hearing loss and pulsatile tinnitus, or a throbbing or pulsing sound in the ear, usually unilateral, but you could potentially have bilateral jugulare tumors in a syndromic patient. Less commonly, you'll have lower cranial nerve symptoms, meaning speech or swallowing dysfunction, or tongue weakness. And then if it's a glomus vagale, which is just a little lower down and originating from the vagus nerve, about half of those patients will have some form of vagus nerve dysfunction. So they'll have a hoarse or breathy voice, but half of them don't, and they'll just have either a palpable neck mass when it's larger, or kind of symptoms of neck fullness or a subjective problem swallowing. And then carotid body tumors probably have the fewest symptoms, except for having a palpable pulsatile mass in the neck on examination. An astute primary care physician might listen and hear a bruit in the neck, or hear vascular flow through the neck. That'd be abnormal. But those ones tend not to present with any cranial nerve symptoms.
Quite a variety of presentations, and I'm wondering if some patients, it takes quite a while for them to get a diagnosis and to make it to your practice. And then are some patients also discovered because of genetic findings and the workup that's done to look for paragangliomas and Pheos?
Yeah, so the recommendation is that if you're found to have a single tumor anywhere, that you should be screened for a SDH mutation if you have a head neck tumor. So to your original point, which is that, often it takes a while for patients to get to us, probably the most clinically occult tumors are vagales, because if they don't have symptoms from that, or they have throat fullness or something like that, people often chalk it up as some benign symptom. but fortunately they're rare. And then genetic mutation carriers, if you find a genetic mutation, which is in 10 to 40% of patients, they should be screened to look for other sites of disease like a concomitant pheochromocytoma or paraganglioma in the abdomen, and to look at other sides of the neck and elsewhere for tumors. The biochemical tests that are often used for workup of abdominal tumor don't have as much of a role in diagnosis in the head and neck because of what we talked about earlier, which is that they don't tend to secrete hormones. But to reiterate the previous point, which is that if you do have abnormalities on that, it's the job of the surgeon or endocrinologist or whoever to look for another tumor.
And we have a whole section coming up on genetic testing in a little bit, and we're going to save some of the good discussion for that. So that was great. Dr. Babanga, you want to continue?
Yeah, I was going to ask Dr. Bonkos a little bit about testing for pheochromocytoma and what tests do you like to use to make the diagnosis for patients with Pheos and Paras?
Yeah, so it's either plasma or urine metanephrines that we commonly use. I use both for different reasons. For example, whenever I pre-order testing for a person with an adrenal mass that looks like it may be a pheochromocytoma, I just go for plasma metanephrines because it can be combined with other hormones that we need testing there, and it's easiest for the patient. But in my patients who need yearly assessments with urine catecholamines and metanephrines because they had a history of pheochromocytoma or have a genetic predisposition to paraganglioma, I would just send a mail-in kit for urine for my patients to collect urine to send back to Mayo Clinic, and then they don't have to go to the lab and find someone to do the venipuncture. Both are acceptable, but it's just important to keep in mind that plasma assessments could come with a higher percentage of false positive results, especially in the normetanephrine fraction. So in the ballpark, it's around 15% false positive results for plasma normetanephrines, while it's only 5 to 6% false positives for the urine. Another thing to look at is the degree of elevation for metanephrines and normetanephrines, because I think the recommendation to wait for metanephrines to be 3 to 4 times above upper normal range is really old. I think that most patients we diagnose currently with paragangliomas have very, very mild elevations of metanephrines and normetanephrines. So I guess I just would like to shout out there not to keep testing a patient and waiting for those metanephrines to increase. If they're high and you exclude false positives, to proceed with the next step.
So to be clear, Dr. Bankos, at what point, at what level elevation of plasma metanephrines will you decide you do not need to do the urinary metanephrines, or do you do urinary metanephrines on everybody?
Now, so any elevation of plasma metanephrines is worrisome to me. So if I see plasma metanephrines elevated even by a decimal point in a person with an adrenal mass that looks like it could be pheochromocytoma, meaning the density that we use Hansfeld unit measurement there is above 10, usually above 20 for pheochromocytomas, I would conclude that pheochromocytoma is very likely in that patient and proceed with the management. With normetanephrines, I probably would first look at medications and other reasons for false positive results, and potentially do a 24-hour urine collections for normetanephrines and catecholamines. So it very much depends on whether those risk factors for false positivity are there or not, and whether they can be changed. For example, certain medications can be stopped potentially or not.
So I have another question. Dr. Babanga, you practice in Alaska, and Dr. Shirali, you practice in Florida. We've got people from Utah, from the Mayo, it's all over the United States, very different practice patterns. Dr. Babanga, what proportion of the time are you doing the workup and evaluation for your patient? versus access to endocrinology, particularly somebody who has an expertise in this?
Yeah, thank you for that question, Dr. Rosen. Indeed, the number of endocrinologists available in the state is limited. It takes patients months to get into see one. And so I do end up seeing many patients, often with incidental adrenal nodules found on other imaging tests. And many times as the surgeon, I'm the one ordering the tests to screen for and to diagnose different adrenal tumors. But I would say the majority of patients I see with adrenal tumors are ones that see me first. And if a few of them come after they have met and seen an endocrinologist.
And Dr. Shirali, for you in Florida, where there's got to be a higher density of endocrinologists than Alaska, what are you thinking about? What sort of things do you do when you see someone, once you think they may have a pheochromocytoma, they've got an elevation of metanephrin? Are you seeing these patients in addition to endocrinology? What additional tests or workup are you going to be doing for them?
Yeah, so we have I collaborate with a great team of endocrinologists here at University of Florida and a lot of community endocrinologists as well. I think that once I have a patient who I see who I'm concerned about a pheochromocytoma with, I really talk to them about whether they feel comfortable being able to see an endocrinologist, because a lot of the issues that people in Florida have is actually driving distance and going to see different physicians, and the kind of time it takes to go see many different providers. And so if they are comfortable seeing an endocrinologist, I do like to collaborate with an endocrinologist in terms of the preoperative workup, so alpha blockade and beta blockade. But I do also manage that myself if the patients don't feel comfortable doing that. And once I do feel, if I do collaborate with an endocrinologist or they are comfortable seeing them, then we frequently co-manage the patient until we get them to surgery, and then afterwards continue surveillance as well.
And that actually brings me to another question that was in the list that I'll direct to Dr. Graham. I mean, we're all well aware of MD Anderson. I'm sure it's a destination for center for many patients. I'm sure that the proportion of patients you see who maybe have advanced or recurrent disease might be greater than someone in a regular endocrine practice. How are you managing your distance patients? How are you continuing to monitor them? Is there a mechanism to continue to monitor your patients long term?
Yeah, thank you. You're right in that we like to follow our patients post-treatment for a longer period of time based on a risk of recurrence and risk of potential spread. So it is kind of important to continue with a long-term surveillance model. We see kind of a large local regional population, but also a large referral population as well. So those that come from further away, hopefully after a successful treatment, then the follow-up tends to be kind of at longer interval surveillance, maybe 1 year intervals to maybe a little bit longer. And so for many patients, that's not too burdensome that they would like to come back and follow with us. In other cases, it's finding a local provider closer to home that specializes in adrenal disease too, that can help take over kind of the long-term surveillance. I think we're kind of a small community of people that really love adrenal disease and treat pheoparaganglioma as well, and so we're able to provide good referrals to providers that may have expertise in it in their local region.
Great. I mean, it's very different models for every place that we practice. Dr. Bancos, what about telehealth or telemedicine, or do these patients have to be seen in person?
Well, so our practice is quite unique because 99% of our patients are not local. So we have to do a lot of hopefully high quality virtual care. So for new patients, there's always a huge advantage to see people in person. And actually, since COVID ended, we are not able to see new patients virtually. Only our follow-up patients can be seen virtually at this point. But I actually do not require visit virtual or otherwise if yearly assessment for catecholamic excess is negative. If I do require in-person thing, that usually means a person needs to have a full body scan, and that needs to be done in person. So it very much depends on a particular patient. If patients are not at high risk for recurrence from metastatic disease, then it's really just yearly biochemical follow-up. If patients are, well, then they would need to come and have some sort of imaging in a good center. So.
And I'm going to turn it back to Dr. Babanga, because we do have quite a few questions about imaging, particularly for recurrence. So, Dr. Babanga.
Yeah, Dr. Bancos, I wanted to ask you a little bit more about the different options for imaging techniques for our patients who may just have a biochemical diagnosis of hormonal other secretion suggestive of pheochromocytoma. Or, you know, for follow-up, what are some of the options, and what option do you choose for which patients?
Yeah, so to start with the most common scenario. The most common scenario nowadays, in this decade at least, is really starting with incidentally discovered adrenal mass. 70% of patients with pheochromocytoma present incidentally. Imaging is done for a reason where no one suspects that pheochromocytoma exists. So really, when we are talking about, well, there are symptoms and then metanephrines were measured and they're positive, that would be the situation maybe in 20% of people. So, I mean, a fifth of all patients, and I'm hoping that in the future it will be less and less. So, because more and more discovered during, because of genetic screening, and hopefully incidentally before symptoms appear. So if we are to talk about the first scenario, which is the most common, I would say that if I have a CT scan with adrenal mass that looks like pheochromocytoma and positive biochemical testing, I do not do any imaging at that point. At that point, patient will be prepared for surgery and referred to genetics. Now, depending on how the surgery went and genetic analysis, I would plan for the next step. If genetic analysis is negative, then I would plan for additional imaging during follow-up, depending on what genetic mutation was positive. If not, that person would be recommended to have forever biochemical workup. So that's the most common scenario. The less common scenario, when patients present with symptoms of catecholamine excess, and we have an astute physician that actually suspects pheochromocytoma, which is 3 out of 300 suspicions, 1 actually is diagnosed with Pheo. Just saying that it's, you know, we frequently suspect it because we think it's, you know, a fascinating diagnosis. And maybe more of us should be suspecting it. But in any case, in those situations, I would still start with cross-sectional imaging, such as CT scan or MRI, because 90% of paragangliomas would be in the adrenal gland, pheochromocytoma, or in the abdominal pelvis. And only if I did not find it, I would do a full body imaging, such as gallium dotatate scan. So I'll stop answering this question for now, and you know, maybe give other people some time to.
Well, this does actually, there are quite a few questions from the group, and please, for our audience, if you have additional questions, type them into the Q&A box. We'll try and get to as many as we can. I'd like to kind of go around and talk about what people use as their initial imaging for patients who we suspect have pheochromocytoma. And then we're going to talk about imaging for recurrence. So I guess we'll start with Dr. Shirali.
So my preferred imaging is cross-sectional imaging with a CT scan for pheochromocytoma. I think that it, as Dr. Bancos had said earlier, I mean, we can use a CT scan, CT abdomen pelvis, without and with contrast. The without contrast really I use for the density to look at the Hounsfield units, and then combine the imaging with the biochemical evidence to really suggest that something is a pheochromocytoma. The reason I prefer the CT scan personally over other imaging modalities is because I use the cross-sectional imaging from the CT scan for surgical planning. And so I prefer, that just might be a comfort level in training, but I prefer the CT scan to help me with surgical planning to determine the best surgical approach that I can use for the patient.
And when do you start doing functional imaging?
So I start doing functional imaging usually in the setting of a mutation. So I will say that is something that I speak with my endocrinologist here at University of Florida about, to kind of come up with a multidisciplinary approach. But I usually do functional imaging in the setting of patients who have a genetic mutation that we've identified with genetic counseling or genetic testing.
Dr. Babanga, up in Alaska, what sort of imaging are you using?
I prefer to use a CT scan, triple phase CT, adrenal protocol as well. And we do also have the availability of dotatate PET scans for patients that we are concerned about looking for metastatic disease or just more of a functional evaluation.
And Dr. Bankos, tell us a little bit about the initial and then the recurrent imaging choices.
Yeah, so again, if it's someone without genetic predisposition, so genetic analysis is negative, initial imaging shows, let's say, a left pheochromostoma that is removed by an expert surgeon, I would not do any additional imaging in this patient in the future unless there is biochemical recurrence, meaning one of those yearly metanephrin tests comes back positive. In someone with genetic predisposition, I would do full body imaging depending on the mutation. For example, well, I should first start by saying that different genetic predispositions comes with different risks and different locations, probabilities of those paragangliomas developing. There's also some syndromes that come with very low risk of metastatic disease, while others a bit higher. So all of this dictates the frequency of full body imaging. It could be every 3 years full body imaging. It could be every 5 years. It could be every year, depending on how concerned we are. And I usually like saying that past history dictates the future. So in a person with aggressive disease, maybe with multiple primary tumors coming up, I would probably do more frequent imaging. Well, in someone who we've been monitoring for 15 years, I did not have any other primary tumor developing, I would do a bit more seldom imaging.
And Dr. Patel, for you, what sort of imaging do you require? Is there anything specific or particular for the carotid body tumors in addition to what we've mentioned?
Yeah, carotid body tumors are pretty pathognomonic on just about any scan you get. So a CT scan can show you just about everything you need to know. The question comes, as many of our other panelists have pointed out, if somebody is predisposed to developing another tumor due to a genetic syndrome, because the curiosity that we have to satisfy is there a tiny carotid body tumor, a tiny glomus or something like that on the other side, that's going to become a problem potentially later in life. And in those situations, distinguishing between a small glomus or carotid body tumor and a lymph node or something else is sometimes difficult for the radiologist. And so then we rely pretty heavily on MRI. For glomus jugulare, which I know isn't the real focus for today's discussion, we use CT and MRI, CT mostly for surgical planning and MRI to assess the extent of the tumor, because where the tumors live, you can't really see much on a CT scan. And then to the point about whole body imaging, again, just as Dr. Bankos mentioned, if there's a genetic mutation, we'll look at the whole body. But I did want to point out one thing, just so that our attendees don't feel like they receive substandard care or something like that. But dotatate PETs are extremely expensive. And at our center, it's very, very difficult to get them covered for screening purposes only. And so just based on our payers. And so we'll often just do an FDG PET, regular PET scan. And the sensitivity and specificity is actually pretty good. It doesn't have the ability to distinguish from, normal hypermetabolic tissue. And then it's less useful around the base of the skull because the brain lights up quite a bit on FDG PET. But that's a reasonable thing to do. What we have tried to move away from is whole body MRI. It's a whole body T2 MRI, which for our attendees to know is probably the least favorite thing for a radiologist to interpret. And there's no contrast. So a lot of things get missed on whole body non-contrast MRI. So it's good to be focal if you're getting an MRI.
Also very difficult to get the timing for the whole body MRI because you need to be screening so fast. So, and then Dr. Graham, and then I'll turn it back to Dr. Babanga.
Yeah, I would say our practice is very similar to what's been said by the panelists. Typically a CT scan, a triple phase or adrenal protocol scan to begin with. Occasionally someone with a very large or aggressive appearing Pheo or paraganglioma may get staging with a PET dotatate as well. It also depends, I guess, on their age and their mutation status. And then for longer term surveillance, it also depends a little bit on the patient's age and mutation status as to whether we may switch over to something, an MRI early on to kind of prevent the long-term exposure with CT radiation and just do MRIs. We use a little bit of a combination of someone's preoperative catecholamine levels to postoperative catecholamine levels to determine, really how reliable can postoperative catecholamines be in terms of the surveillance of a patient. If a patient, corrects their levels well, then we're feel confident in kind of following that as a long-term surveillance model. Perhaps if they didn't drop appropriately or they were not very high at the beginning, then we may depend a little bit more on imaging as part of our surveillance modality in the future.
Great, thank you. And does it matter where you get your scan? So are these the kind of scans that can be done anywhere?
I would argue that it's nice to do the scans in places that have capability to do 3-phase scans. So those places that commonly do liver, pancreas, adrenal protocols, because the timing of which the contrast gets to that area of concern is very helpful. Additionally, places that do these often also have perhaps slightly thinner cuts of CT scans, which is very helpful in determining surgical approach in some aspects at times. So now that often is a luxury that's not, available to many patients depending on where they live or their background. So, obviously those are kind of optimal, but in kind of the basic form, a contrasted scan to highlight the tumors is very important.
Thank you.
Thanks, Dr. Dr. Graham, I wanted to also ask you if you could tell us a little bit about the surgical approaches to adrenalectomy for pheochromocytomas and also partial adrenalectomies or cortical sparing adrenal.
Yeah, thanks for the question. So I think the surgical approach to pheoparaganglioma really depends on a lot of patient and individual tumor specifics. The patient's tumor size, the location, the potential for invasion locally or metastasis, whether it's a genetic tumor or whether it's a sporadic tumor, meaning one that's not hereditary in nature. And then probably the surgeon's familiarity with a specific approach on how they perform most of their surgeries. So kind of in general, we would say larger invasive tumors are typically resected by an open laparotomy or an open surgery to remove the tumor intact and then completion. We would say most smaller tumors to kind of mid-size or even large tumors can be sometimes can be addressed in a minimally invasive fashion. And minimally invasive may mean different things to different surgeons. They may present or perform these in a robotic approach through the belly. They may do it through a laparoscopic approach through the belly, or sometimes like we do through a retroperineoscopic or through the back approach. But into your other part of the question, a cortical sparing approach is sometimes where we want to leave the outer portion of the adrenal to help preserve a little bit of steroid function throughout the body, and that can sometimes be performed in specific cases and specific mutations. That I think is important to kind of to really determine who's appropriate for that, so that you decrease the risk of possibly fracturing a tumor and leaving a little bit behind, or increasing the risk of recurrence. So I would say kind of surgeon familiarity and experience in these matters that really helps improve outcomes. And in that same situation, high volume centers, high experience tend to improve those outcomes as well.
Just to follow up on that, that's an important point to bring up, because there are high volume centers, and recently some centers have been designated by the Pheo Center of Excellence. And so, Dr. Shirali, would you mind telling us a little bit about what it required? I know your center at University of Florida recently became a center of excellence. What was involved in getting to that designation?
Yeah, absolutely. So as you said, Dr. Banga, we were recently recognized as a clinical center of excellence, and I really want to appreciate and acknowledge the Pheo Para Alliance for that designation. So currently, UF is the only clinical center of excellence in the Southeast United States. So we see patients with Pheo and paraganglioma throughout Florida, Georgia, and Alabama, and really extending even more north and west. And I think being recognized as a center of excellence has given patients who have this disease really improved access to specialty and multidisciplinary care. Centers that have this designation must fit pretty specific criteria outlined by the Pheo Para Alliance to provide high quality multidisciplinary care. So some of the requirements are, first, multidisciplinary expertise. So the centers must have an endocrinologist, endocrine surgeon, or surgical oncologist, head and neck surgeon, nuclear medicine specialist, a radiation oncologist, genetic counselor, and pediatric endocrinology. In terms of diagnostics, so of course CT and MRI, but also genetic counseling and genetic testing, but also functional imaging such as dotatate, as many have already talked about. Surgeon experience, so the Pheo Para Alliance has certain case volumes that need to be met. I think the number is at least 20, but usually much higher surgical procedures per year on Pheo and paraganglioma. But in addition to just case volumes, really specific capabilities must be provided. So as Dr. Graham suggested, minimally invasive adrenalectomy, whether that's laparoscopic transabdominal or retroperitoneoscopic adrenalectomy, or robotic adrenalectomy, cortical sparing adrenalectomy, thoracic, abdominal, and head and neck paraganglioma resections as well. But I think one thing that is very important for a center of excellence is to have a patient navigator and patient ambassador to facilitate patient consultations and to coordinate care. Because in areas like North Florida, where there's really quite poor access to specialty care, it's very important for patients to have someone who can coordinate their care so that they don't have to travel 200, 300 miles every other week to see a different specialist. And so I really give a lot of credit to our patient coordinators for coordinating the care of the complex care of these patients.
So I actually there is a follow-up question to that. We're really going to separate the surgical approaches to pheochromocytoma from the surgical approaches to paraganglioma, if that's okay, because they are really very different. We've talked a little bit about some of the surgical approaches to pheochromocytoma. There are quite a few questions for Dr. Patel about when you choose to operate, how extensive your operation is, what does unresectable mean, and how do you manage those patients?
Yeah, so years ago, and actually not too many years ago, I should say, radical resection for glomus jugulare tumors was kind of the standard of care, and it would leave people neurologically devastated. You'd have a unilateral, especially in a sporadic patient, somebody who doesn't have a genetic syndrome, a unilateral vagal dysfunction, shoulder weakness, tongue dysfunction, sometimes require a feeding tube, a tracheostomy tube. And then if you add the syndromic patients or people with SDH mutations, now you have tumors on both sides. They may, even just by their own doing without any intervention, cause lower cranial nerve dysfunction. And that's a huge life-altering event. And so most of us have gone pretty far away from that. It's quite rare, and I put it in some of the answers to our attendees' questions. It's quite rare that I'll go for a radical resection of a glomus jugulare tumor unless it is exceptionally large, presenting some, neurologic threat, brain stem compression or whatnot. And so what we'll often do, or just to keep it relatively simple, and this again doesn't apply to every single case, but just to try to keep it simple, if somebody has a small to medium-sized tumor and they have no symptoms or very few non-bothersome symptoms, I'll use primary radiosurgery, which some of you may have heard of Gamma Knife, CyberKnife, Linac-based treatments that can be delivered at a number of centers, including ours, and even places that don't have a lot of Pheo experience. And then if somebody is symptomatic, then we'll usually go for an intentional subtotal resection. So I tell the patients that if I come out and tell you that I took out 80% of your tumor, that's a win. And the goal is to leave their nerves alone and then treat the residual tumor if it grows with radiosurgery. And that's true for glomus jugulare. For carotid body tumors, the outcomes in experienced hands are actually quite good. The risk of lower cranial nerve dysfunction is much lower unless it's a very big one. And then with vagale, just is probably the simplest one. If the nerve works, don't touch it. And if the nerve doesn't work and it's big, you can go for it. But just one final comment about it. All head and neck paragangliomas grow. No matter how you slice it, they all grow. Some grow slow, some grow fast. Sometimes it's dependent on their syndrome, sometimes it's not. But it's not, the growth doesn't influence whether you develop a nerve problem. So for the patients out there, if your tumor grew 2 millimeters, that doesn't mean that a nerve dysfunction is right around the corner. In fact, in observed tumors over at least short to intermediate term follow-up for a few years, the incidence of a new cranial neuropathy is actually very, very low. So growth is not the only thing that influences the decision to intervene.
Complicated. I'm glad there are people like you to manage these complicated patients.
Thank you. Dr. Bancos, I wanted to ask you a little bit about the challenging answer that you sometimes have to give to patients when they ask about whether their tumor is benign or malignant, and how we determine that. If you could speak a little bit about the new World Health Organization reclassification of paragangliomas and pheochromocytomas.
Yeah, so I used to be telling my patients that it's the only tumor I know of that it's neither benign or malignant, or at least we cannot really answer this question based on pathology. But to be a bit more scientific about it, WHO calls all paragangliomas as malignant tumors, but the potential for metastatic disease very much varies. That's what it is. So this is why, after removing a pheochromocytoma, we keep testing urine metanephrines once a year forever. Because there is nothing in the pathology that would tell us that it will never come back. Now, the risk for some of these tumors to come back could be minimal, such as 1%. Those are the patients we would not do imaging again. We would just do urine or plasma metanephrines once a year, but it's not zero. So now, what diagnoses metastatic paraganglioma? It's finding it in the tissues that paraganglioma should not occur. And really, the only one that is 100% where paraganglioma should not occur is bone. So if we find a paraganglioma in the bone, it is 100% metastasis. Now, there are other organs where metastases go, and that would be lung and liver quite commonly. But actually, there could be some primary paragangliomas occurring in the lung and liver. I've never seen one. All I've seen so far in my career were metastases to the lung and liver, but it is possible apparently. So, so really the definition of metastatic, I guess it would be better to classify it metastatic or non-metastatic and not malignant versus benign. And I think this is the message I'm trying to give to my patients. I can talk much more about it, but let me sort of like stop for now and see how you want to direct the conversation further.
There, there are so many questions from the group. Two, I think, easy questions to address before we move to talking a little bit about genetic testing. So, Dr. Shirali, can you live with just one adrenal gland?
Yes, you can live with one adrenal gland. As long as that adrenal gland is producing enough cortisol, glucocorticoids, really, and mineralocorticoids, you can live with one adrenal gland. Some people do feel that there is some difference, but I think that most of the time, the majority of people live perfectly fine with just one adrenal gland.
And a follow-up to that for Dr. Graham, because to be honest, every one of the topics we've talked about could be an entire webinar. We could talk about imaging, we could talk about labs, we could talk about genetic testing for 3 hours, every one of them, and talk about interesting patients. So Dr. Graham, why do we talk about doing partial adrenalectomies when you could do a bilateral adrenalectomy, put somebody on steroids, and many of them do well? So why save the adrenals?
Yeah, it's a very good question. So in some genetic syndromes, we know that a patient may have a higher risk to develop pheochromocytoma in both glands. And so the possibility of having bilateral pheochromocytomas and then the possibility of having bilateral adrenal glands removed in the future may render someone adrenal insufficient or without the steroids that they need to survive, and they may be dependent on the steroids in a daily supplement, and sometimes at higher doses for stress events in their body, like severe illnesses or sicknesses and those factors. So if we have an idea based on maybe their genetic predisposition that this is a low risk of being a metastatic Pheo, then there's a potential to save a little bit of the gland, again, that outer portion of the gland, to try to preserve some of that steroid function, potentially rendering them without the need to take steroids all the time, or at least without the higher doses of steroids. It does come with the slight risk that there is a little bit of medullary tissue still left within that normal adrenal tissue, and that can predispose someone for a recurrence of the tumor at that spot, or even development of a new tumor. So there can be a debate among some practicing providers that maybe to prevent that recurrence is just to do a total adrenalectomy or remove the whole gland. And in the case of bilateral tumors, maybe bilateral adrenalectomy and be on steroid replacement. But I think in a lot of our practice, my practice, I tend to try to preserve some cortical tissue if a patient has a low risk of a metastatic or malignant process.
And we know that steroid replacement is an art rather than a science, right? Dr. Babanga.
Yeah, well, that leads us into a pretty important topic that's just been growing in the recent years, and that is genetic testing. We used to think that a small percentage of patients with pheochromocytoma and paragangliomas used to be the rules of 10, and only 10% had genetic abnormalities, but now we know that number is much higher. Just wanted to ask the panelists, how do they approach genetic testing with their patients? Do you order it yourself? Do you send a patient to a genetic counselor? Do you order a panel or a specific test? And then how do you use it in patient management, which I know that's a big question. I'll start off with Dr. Shirali.
Yeah, Dr. Babanga, exactly what you alluded to. I mean, I think we all used to believe the rule of tens many years ago, but now nearly 40% of all patients with pheochromocytoma and paraganglioma are found with an inherited mutation that may be responsible for the development of these tumors. Because of that, I think a lot of us, including myself, believe that all patients with Pheo and paraganglioma should undergo genetic counseling at the time of diagnosis. Right now, there are over 20 susceptibility genes that have been identified so far, and really we're finding more and more with each year. So, to answer your question about whether we recommend panel testing or individual testing, I would recommend panel testing, just given the fact that there are so many susceptibility genes that have been identified. Now, in terms of testing versus counseling, how that is completed, I think it's really very provider dependent, but I really do place a lot of value in genetic counseling, whether that's done by a certified genetic counselor or a provider who has a lot of experience in genetic counseling or genetic testing, because it's really more than just ordering the panel of Pheo or para-associated susceptibility genes. It's about performing a really thorough family history, creating a customizable panel that encompasses genes that are relevant to the patient, not just necessarily Pheo and para, but other diseases or syndromes that may be associated or found in that patient. Further, I think genetic counselors can really discuss the finances of the test, how to interpret unexpected results, such as variants of undetermined significance, and also implications for family members. I think one issue that people have is finding genetic counselors. I think it's really challenging unless you're in areas that have established genetic counseling programs. It might be difficult, but I've spoken to a couple of our genetics counselors, and there are some websites that can be used, and we can provide that in the chat, to find a genetic counselor in their area, a certified genetic counselor in their area, or actually find one who can do telemedicine visits so that you could establish care via telemedicine if that's allowed for your practice. And in terms of how I incorporate that into my practice, I think it's, again, very dependent on the surgeon or the endocrinologist, but I really try and push for genetic counseling for all of my patients. I try to do it before surgery if I feel like it would change management. And as Dr. Graham had alluded to, I think that I find it most helpful in patients who I think I can perform a cortical sparing adrenalectomy. The last thing you want to do is perform a cortical sparing adrenalectomy in someone who has an increased risk of malignant disease. So patients with SDHB mutations, for example. And then if you find patients who are at increased risk of bilateral pheochromocytoma, such as patients with RET mutations or VHL mutations, I would be more inclined to consider a cortical sparing adrenalectomy in someone who's younger, to give them, many years of essentially preventing or trying to prevent permanent adrenal insufficiency if they were to develop a contralateral pheochromocytoma. So that's how I try and incorporate it into my practice. But I do believe that all patients with Pheo and paraganglioma should undergo genetic counseling or testing.
Excellent, thank you. And Dr. Graham, anything that you do differently, or how do you use the genetic information that you have for your patients for surgical planning and for follow-up?
Yeah, no, I think Dr. Shirali said it very well, and I would agree. A lot of similarity in our practice, and that we would say most of our patients or all our patients typically get full adrenal lab panel or genetic panel testing to assess for most of the known genetic mutations. Occasionally, we'll have patients that are first diagnosed with a different disease process, like a VHL or neurofibromatosis, and they may not go through that pathway. But for the majority, they will go through panel testing. We do have a genetic counseling available to our patients, and we do encourage that. I think for the reasons that Dr. Shirali eloquently said, I think it's very important for a patient's understanding, for an understanding when it's not straightforward, for an understanding of their family planning and risk factors. So, and then lastly, I agree that it is very important for, I think, surgical planning. for initial planning in terms of approach, but also for the long-term surveillance, as Dr. Bancos was saying earlier. Those that have a higher concern based on the mutation may get different types of follow-up in terms of imaging and labs versus just labs, and maybe the frequency may vary a lot too.
Well, I think sadly we have come almost to the end of our hour. As we said earlier, we could so easily talk about every one of these topics. So I think we're just going to go around and get some last thoughts from our panelists, and I'll close out the session with my own thoughts. So I'm going to start with Dr. Bancos.
Well, I feel that we could talk about this for another 3 hours. That's my main thought right now, because I feel like there's still so much to share. I just wanted to thank you for the invitation. It was great to hear from my colleagues, and I would like to thank all the participants and who attended to listen to all of us. Thank you.
Dr. Patel.
Yeah, I would echo that. I just want to thank everybody for including us and for tuning in. These are really complicated topics to talk about, as we've alluded to, but finding a center that has all the disciplines covered and providers in each of the relevant areas is really important. If you can't, I would just put in a plug for Pheo Para Alliance and saying, you can always reach out to them. We do get quite a few. I sit on the medical advisory board and of Pheo Para Alliance, and we get the occasional message from a patient saying, I don't really have good access to somebody nearby, or I'm worried that something about my management isn't quite right. Even if you can't go to a center of excellence or something, that doesn't mean that every other center is not excellent. That just means that we know a lot of people around this network that's relatively small of surgeons and endocrinologists and oncologists and radiation oncologists and people with this experience. And so just don't suffer in silence. Always reach out. And thanks again for the opportunity.
Thank you. Dr. Graham, last thoughts.
Yeah, thank you very much for the invitation. I enjoyed it very much. And I agree with Dr. Bancos. We could talk for a long time. So thank you for the Pheo Para Alliance for setting this up. I would echo what Dr. Patel said, is that the new diagnosis of this is sometimes very confusing and very anxiety producing for our patients. I would say don't be rushed into kind of treatment or management when there may be uncertainties or unclear. Always feel free to seek a second opinion or expert opinion. We have Florida to Alaska and in between covered here, so there's somewhere that can help answer a lot of these questions before kind of commit to a direct surgery or direct treatment.
Dr. Shirali.
Yeah, thank you everyone for giving me the opportunity to be on this panel with really incredible surgeons and endocrinologists. I mean, what everyone said, I completely agree with. I think that the diagnosis and management of patients with Pheo and paraganglioma is challenging. And I think finding endocrinologists and surgeons and medical professionals to diagnose is really challenging. And resources like the Pheo Para Alliance can really help patients navigate these difficult scenarios and kind of finding the right situation. And even though I think, in the chat, a lot of people have said they don't have providers close by, I think going to the Pheo Para Alliance for looking for resources or reaching out to any of us to see, to use our network to find people who could be close to you would be really helpful. Because as Dr. Patel said, I mean, you don't have to be at a clinical center of excellence to provide excellent care. And I think there are a lot of surgeons and endocrinologists throughout the country that can manage these, and we know a lot of them. So yeah, again, thank you for the opportunity. I really appreciate it.
Dr. Babanga, last thoughts before I close us.
Oh, thank you. What an excellent group of amazing surgeons. Thank you to everyone for their input and to the participants. And I would just recommend making sure that everyone uses the American Association of Endocrine Surgeons website for patient education material, as well as the function for finding a surgeon in your area. Thank you.
And I'll close. I'll echo what everybody else said, but I'm also going to say this, which is these are incredibly complicated patients and complicated tumors and complicated problems. And many of us are seeing patients who have already had surgery elsewhere. There's complicated decision making. Anyone who embarks on operating on someone who has a pheochromocytoma or paraganglioma is really trying to do their best job. But then sometimes recurrences are very complicated to manage. So don't think that you're alone in that. So thank you very much for your time. We'd love to talk again. And I look forward to seeing some of you as my patients.
Thank you all. On behalf of Pheo Para Alliance, I want to thank everyone that signed up today, and also this incredibly amazing panel for tonight's discussion. Thank you so much. And thank you for doing double duty by answering questions in the Q&A box too. You're all heroes, I think, to many people here tonight. Thank you.
Good night.